Okay, so welcome back. That was just a little show filler, something I hope to make you chuckle and give you a little bit of insight into us as, do I deliver? Sure. I do love to cook, and thank you for indulging me in that little foolish video. So it is my absolute pleasure now to introduce to you our next speaker. And so I am going to stop sharing, and we are going to look at Emily's presentation. So Emily, I am going to ask you to stop or to start to share. And Emily is one of the newest members of our board of directors, and I just can't say enough good things about Emily. So you will see that. Have we got Emily on board, and are you able to share your screen?
I am here, and
you are, and
you're probably seeing my inbox right now.
Yes.
And now you should be seeing my presentation.
Absolutely.
Perfect.
So Emily Hyde comes from the beautiful province of Manitoba. It looks like she grew up in Ontario and then deserted them. So she is our Director of Education in CCCN. She has just newly achieved her master's degree in nursing, so congratulations. And this is some of the work that Emily has done. So Emily works as a staff educator in her inpatient cardiology unit, and I very much look forward to hearing a little bit about Sexercise. So Emily, I will hand the mic over to you.
Thank you so much. I'm just gonna pop to my next screen. So thanks for having me. I didn't look at how many people are virtually out there. I'm glad that I'm not looking at your faces in an auditorium. I don't have to picture you all naked to keep myself calm. Sue did show me that she's wearing pants, so that's hopefully everybody is somehow dressed. But yeah, this is the final work of my thesis project. I did my thesis, University of Manitoba, Faculty of Health Sciences, College of Nursing. And you can see my committee members are listed on the screen there. And really, we're going to talk about strategies to facilitate sexual health education. My work was specifically related to people who survived ACS and who were receiving education in cardiac rehab programs. And highest level overview is just start with Sexercise. So if you would like to zone out for the next 30 minutes, just remember Sexercise. So I'm going to start off a bit slow, bit of background, some definitions. Important though, so that we're all speaking the same language and we're all on the same page. And first definition is about sexual health. The World Health Organization defines sexual health as a state of physical, emotional, mental, and social well-being related to sexuality. Really importantly, it's not just the absence of disease, dysfunction, or infirmity. Sexual health requires a positive and respectful approach to sexuality and sexual relationships. And I really like this definition. It's used by a couple of our consensus documents about sexual health. And I think that's really important because it really pushes us beyond physicality and that usual focus on disease transmission, pregnancy, erectile dysfunction, and things like that. They're important to focus on, but they're only one part of that whole picture of sexual health for patients. So important that we're defining sexual health in a way that makes us broaden out that scope. So a logical question that comes up, and usually one of the first questions that I got when talking about my research after I kind of got the stare and silence is, well, why do I care about sexual health? What does this matter? Well, patients report and demonstrate a lack of knowledge related to sexual health post-ACS and fear about returning to sexual activity post-ACS. And actually there is reports of reduction in sexual activity ranging from 13 to 75% post-ACS. So a lack or reduction in sexual activity post-ACS is linked with increased rates of depression and anxiety. We already see depression and anxiety in ACS survivors when we don't even look at sexual health. And depression and anxiety are linked as causes of ACS. So this is really significant. If we can do something fairly simple, like providing education to help decrease that fear, depression, and anxiety, we're going to see a huge improvement in patients' quality of life. And this is really what led to my thesis work. We know patients are uninformed. We know there are negative consequences of being uninformed. There's lots of information out there about what we need to provide, but why aren't we providing this education? And this really came from my clinical work. Some of my colleagues did a workshop at CCC several years ago about incorporating sexual health education into our practice. I reflected back on my own practice and remembered the one time that I had been asked about sexual health, and it was by a patient's wife. He was still in the cath lab being stented after presenting with a STEMI, and I was shocked that someone was asking me about sexual health. I'm a bit judgmental, like, your husband's in the cath lab still, like, this is the most important question that you have for me. And I'm okay saying that because I know I'm probably not in the minority. Hopefully there are some better people than me out there, but that's a pretty common occurrence. Thankfully, I worked with a nurse who was better than me, who stepped in, answered some questions, and really gave that wife what she was looking for information-wise. But then after that CCC workshop, I came back to Manitoba and was talking to some of the nurses that I work with. And when I asked them, if a patient asked you about sexual health, what would you say? Oh my gosh, red face, eye contact averted. I wouldn't even know what to say to them. Or, oh, they're just being pervy, so I wouldn't answer their questions. But really, it's an important part of our lives. Most of us are here because two people had sex. Why can't we talk about sexual health with people? So I really dove into the literature to explore this topic through my thesis. So brief summary of the entire project before we dive into the meat and potatoes. We performed and published a scoping review, which is on the screen. The findings are on the screen there. It's factors shaping the provision of sexual health education for adults with ACS. And this scoping review really confirmed limited to absent provision of sexual health education to ACS survivors. And it highlighted the macro, meso, and micro level factors that influence the provision of sexual health education. And these are super important because the information is there, but we're still not incorporating this into practice. So really, these factors are those reasons. And I think we need to become aware of why we're not doing something so that we can change the structures that exist and that we exist within so that we can provide this education. At the macro level, societal and cultural factors were noted to prevent sexual health education. Who initiated discussions differed between cultures. Often in the US, survivors were initiating these conversations versus, say, in Spain, physicians were initiating conversations. At the meso level, the hospital environment, not the most private environment. Our lovely curtains between beds are really not soundproof. So people really felt there was that lack of privacy. And patients are really in hospital for a limited amount of time. Even some of the older research where patients were having 5-6 day stays, sexual health was just repeatedly reduced. The importance of it was just repeatedly reduced because it's more important than I talk about medications. It's more important than I talk about symptom management. Instead of kind of reframing that of, here's a guideline recommendation, how do I include this? Also, a consistent lack of education related to sexuality. I do not remember learning about sexual health in my nursing program, did not graduate that long ago. So I think it makes sense. If we're not educated, we're not going to have the knowledge. And as a healthcare provider, I'm not going to teach something that I don't know. At the micro level, really, healthcare providers were concerned about bringing up sexual health with their patients. They developed this relationship. Is this relationship going to be ruined? Is this person no longer going to want to talk to me and open up to me? Am I going to embarrass them? Am I going to offend them? Do I really want to talk to my 75-year-old about sex? And rather than receive this education independent of their partners, patients had reported, and that we found in this scoping review, that they really want their partners involved. They don't want to have to repeat information to their partners. So that was an important finding as well. Lots of biases. Younger survivors were more likely to receive sexual health education than older. Women expected and received less sexual health education compared to men. And if you were married, you were more likely to receive sexual health education compared to non-married survivors, even if you were divorced or if you were widowed. And there was a real lack of role clarity noted as well. Healthcare providers didn't know who was responsible for sexual health. So one of those things, if it's everybody's job, it's nobody's job. Survivors wanted their healthcare providers to talk about it, and healthcare providers thought, well, if they don't ask, they obviously don't want to know, so I shouldn't have to talk about it. Nurses thought that survivors should initiate conversations, and nurses also thought, if a patient asks me, I should be referring them to their physician or to a specialist to provide this education. So lots of barriers in here, but this scoping review also really led to my actual thesis project that we'll move on to talk about, because every study that I looked at really approached providing sexual health education from a deficit standpoint. What are those barriers? Let's talk about the barriers. Here's all of the reasons why we can't do it, which is fine, but nothing that I read or that I found really looked and spoke to healthcare providers and asked them what's working. Someone out there has to be talking about sexual health. How are you doing this? How can we identify some facilitators that can help us and can help other people to identify best practice and absorb that into their practice? And how do we identify some of those structural pieces that we need in place to provide this? So my thesis work involved interviewing 8 cardiac rehab staff to understand their experiences of providing sexual health education. And we took a strengths-based approach. So really looking at those facilitators, what has worked? How are you providing this education? And instead of focusing on what isn't working. And we also took a sex positive approach where talking about sex is no different than talking about other topics like medications or symptom management. It's just another thing that we talk about. So an overview of the findings will be presented today, and it's really a knowledge utilization focus. I love research. I'm going to assume that not everyone wants me to get like into the gory details of interpretive description and how I analyze my data. If that is what you were hoping for, we can chat. And our manuscript was just submitted for publication. I've been obsessively refreshing to see what revisions I'm going to need to do. So I'll share that information once that is out as well. So I'm just gonna add a for clarity's sake here. When I say participants in this talk, I'm talking about the people, the 8 people who sat down to share their knowledge and experiences with me. I know we often talk about participants, patients, clients, kind of in those different contexts. If I'm talking patients, they'll be called patients or ACS survivors. When I say participants, it's those 8 healthcare providers who shared their knowledge and time with me. So all 8, the 8 participants worked at 4 cardiac rehab sites. 3 of these 4 sites include sexual health education formally in their programming, which is pretty cool. Across a systematic review that was done, that's pretty uncommon in Canada. So big kudos to Manitoba. We are cutting edge in some ways. The other site, the 4 site had included sexual health education previously. And the participants were able to provide really great insights into what works to provide sexual health programming. And the findings of our project are grouped together as the attitudes and beliefs, the finesse of sexual health education, and the facilitators. So for attitudes and beliefs, my participants really noted that sexual health is still often viewed as taboo, but it doesn't need to be. When participants said we have these preconceived notions or thoughts that we have instilled in us that perhaps limit us from having these conversations. And another person said, I think for some people, there's still a perception that this is really private. Like, I'll tell you about my blood pressure, I'll talk about my sleeping problems, but this part of my health is a boundary that I'm not comfortable crossing. But really, the participant said we need to move beyond this discomfort. It's a social construct. We are taught from a young age that sex is private. Depending on how you were raised, maybe sex is bad, sex is wrong. That's, you know, it's a taboo topic. But come on, we're nurses. We talk to patients about their bowel habits. If you can talk to me about your poop, you can talk to me about sex. So really, I encourage people to challenge yourself, bring up sex in conversation and really challenge that social construct. We can talk about lots of things that previously, maybe 50 years ago, weren't okay. Let's make this something normal to talk about as healthcare providers. It was really neat because my participants often link sexual health to exercise. So I call that Sexercise, even if they weren't a activity or an exercise specialist. And I think that was that really easy way to normalize it, to talk about it. We're comfortable talking about exercise and cardiac rehab. So let's talk about exercise in relation to, or sex in relation to exercise. Lots of quotes, it's no different from exercise, sexual activity is physical activity. And one of the participants did a really great job of asking patients what questions they had. And the questions that patients often asked her were, how hard can I go? Will I have chest pain? So patients are linking sex and exercise, and we are also, so start there. Build your confidence. If you're more comfortable talking about exercise and less comfortable talking about sex, put sex in that bubble of your comfort and grow that comfort. And then you're able to then hopefully expand to those mental, emotional, and social components. So the finesse of sexual health education are those things that we can do to make it easier to provide. And first, you just need to address it. Participants in my study said that patients often don't bring up their questions, saying they haven't had questions in a long time. It doesn't come up super frequently. That means we need to ask, and we need to bring it up and provide the education, and then not just say, shoot me an email with any questions, but really then go back to people. We do have that one-on-one time often when you're on the track in cardiac rehab, or we can find some one-on-one time and ask patients, follow up. I'm sure we follow up on other questions. So make it a safe place for them to open up and ask questions instead of expecting them to come back to us to ask those questions. My participants also noted that it's really easy to exclude sexual health or sweep it under the rug. It's one of those topics that a lot of cardiac rehab programs just don't spend much time on. So Instagram's full of memes like don't skip leg day. If my husband hates cardio, so I swear he pretends like the rower that he bought, because then he'll do cardio, he pretends like it isn't there in the basement. So then he's not using it, it just doesn't exist. He's also a dietitian and he hates eating anything other than chicken. So we'll pretend vegetables don't exist, but we can't just pretend something doesn't exist and expect it to go away. And it's the same thing with sexual health. This need is still going to be there, that need for education, and that depression, anxiety, and fear is not going to go away just because we ignore the elephant in the room. So we need to make a conscious effort to include this in our education for patients so that they are getting the information that they need. Because at the end of the day, it's not about me and my discomfort. It's about the patient getting the education that they need. One thing that was brought up pretty consistently that really does help facilitate sexual health education is the timing. Groups need time to come together. One participant said they have several weeks for the groups to get acclimatized to one another and to get to know one another before they formally present sexual health information, which is totally fair. If I walked into cardiac rehab the first day playing like Let's Talk About Sex by Salt and Peppa and Heaven the whole talk, I'm pretty sure you're gonna have a room that's just like shut down and staring at you like you're crazy. You need that time to get to know one another, build those relationships, build that comfort. And really it may come down to timing and educational needs. If you really don't understand your medications, you're probably going to want to know about those before you're able to engage in questions about sexual health. Same thing about symptom management. It's important, but there's a lot of important things in cardiac rehab. So let's get that timing correct and make sure that we're giving this to patients at the time that they're most able to utilize that education. And so you don't get that look around the room of like, absolutely not asking questions, big note from me, too soon. So there's a few facilitators of sexual health education, and they're pretty logical. You need to know the material. You need to review the practice guidelines. There's lots of them, they exist. I'll show you guys a consensus document after. I'll probably have some time. And it's a great consensus document. It will give you all of the information that you need, but obviously that's not enough because we're not doing a great job of providing this education. This is just one piece of what we need to do. And participants recognize this. How do you get your staff ready to talk about it if no one's ever taught them about it? One participant was super self-directed and said, if someone asks me something, I'll just look it up if I don't know. If I hear something, I like to read about it, which is great. And then how do we share that information back? How do you make sure that it's not just you that has this information, but we can share that with our whole team? And really, you can't teach something you don't know anything about. I had to back up a neuro lecture recently. There's cranial nerves. There's a few of them. They do things to your face. I don't really know much about them, so I can't teach it unless I read about them. So I needed to look up the material and understand before I could teach it. It's the same thing with sexual health. A really interesting facilitator is the need for communication skills. And I say interesting, this hasn't been reported in literature previously. No one's ever linked that ability to communicate and separated that from, say, confidence or knowledge of the material. But some of my participants said things like, you know, when you get that first couple presentations out of the way, you find your niche, you find your flow, and it just becomes normal. Once you start talking about it, it's easier in the future than if a person has never had exposure to doing talks before. So it makes sense. You give me a microphone and a stage and I will talk. I will be asked about cranial nerves if I need to. I'm comfortable presenting, so it's easier for me to talk about something that maybe I'm not as knowledgeable or comfortable with because I can just talk. So we need to give people those tools and we need to foster that ability to have those conversations and open up in front of a group, and then how do you start a difficult conversation with someone that's not socially acceptable to talk about? How do I just walk up to Fred that I've known for 6 weeks for an hour every day to be able to start talking to him about sexual health? I need to learn some of those skills first. The last facilitator is really engaging in dialogues about sexual health education with colleagues, because silos exist. No matter where you work, no matter what program you're in, there's always going to be some sort of siloing happening when we're providing care. And it makes sense. I mean, no one has time to sit in and listen to what every single person is teaching, doing, or working on. It would be great if we did, but we would have spent so much time doing that, we may not be able to get our work done. And that's what my participant shared. One said they have no clue what a different provider talks about in the sessions that he does. He sat in on one years ago, but he can't remember what that was. And someone else said, people might not be comfortable bringing up sexual health at staff meetings. Is this going to be a red flag to admin? So if no one's talking about it and no one's giving permission to talk about it, then that makes it a little bit difficult to have open, honest conversations and have sexual health education in our cardiac rehab programs. If I don't know what the mental health expert's talking about, I'm going to start basic, but maybe someone else has already covered that. And really, let's break down those barriers between our colleagues. Like, have fun at a staff meeting. Tell your admin that you want to bring this up, and let's play salt and pepper. Let's break down some barriers, have some fun, and make sure that we're including this information. So altogether, this is an infographic of our final work, and this is what we think healthcare providers need to know to provide sexual health education to patients post-ACS. So we need to define sexual health to understand what we're going to teach and make sure that we're providing education on all those aspects of sexual health. Really helpful so that we hit those multiple layers. We need to understand why it's important to talk about sexual health. I can drill home it's a guideline recommendation, and that does mean something. I'm not saying guidelines aren't important, but hearing that patient voice and those negative feelings that patients can have and that negative impact on quality of life can really be impactful. And that patient voice is super important when we're talking about why we should do something that maybe we're not super comfortable doing. We need to challenge our attitudes and beliefs. Sex does not have to be taboo. I actually really enjoy talking to people about my topic because people get really uncomfortable when they're kind of the usual conversation. Oh, you're doing your master's, what's your topic? Oh, I'm talking about sexual health and how we provide that education, is usually the initial response. And then, oh, that's nice. Why is it taboo? It doesn't need to be. So really, most cardiac rehab staff are comfortable talking about exercise. Use that to your advantage. Start with Sexercise. Start talking about it with that exercise focus, and then grow that comfort. And really bring up sexual health and don't wait for patients to ask. Initiate conversations, follow up with them, and actively ask if there's any questions that they have about sexual health. This can be formal, it can be in your one-on-one time, whatever your comfort is and whatever works for your program. We really need to reflect and make sure that we are actually providing this. I think a lot of the times you're never going to go to work and be like, I did a really bad job today and I'm really proud of that. So we need to actively reflect to make sure, am I actually asking? Am I actually following up? Because I may think I'm doing it, but let's just critically look at what we're doing and could we do it differently or do it better? Review what's being taught, make sure sexual health education is included, and don't exclude it. It's a guideline recommendation. We should be being able to check off that we're providing every guideline recommendation. So don't just sweep that one under the rug and forget to talk about it. Start with Sexercise, let it grow. Don't let sexual health be leg day. Don't exclude it and pretend like it doesn't exist. Cardiac rehab programs are definitely the right spot to provide this education. We need to recognize there's lots of information that needs to be provided, especially as hospital stays get shorter and shorter and shorter. That education in cardiac rehab becomes more and more important. It's all important. And you don't have to spend 6 hours talking about sexual health, but we do need to make sure that it's there and that we are providing it appropriately. And after, we're allowing groups to come together and those relationships to build. There's really great guidelines. I'll show you the one consensus document that I would really suggest everybody read. The information is out there and we can utilize it. There are the formal guidelines. There's lots of experts. Winnipeg has a PhD prepared sexologist who's able to provide education. There's lots of sexual health seminars out there. So really thinking beyond typical research and typical evidence, how do you provide or how do you gain knowledge? Research evidence is definitely one way, but if you worked in women and child for years and you're really comfortable talking about sexual health that way, you're a great resource to your peers as that clinical expert and that clinical expertise that you have. How have I talked about these difficult topics previously, and how can I apply that to this? And then really patience. I think that's one thing it's a master's project, so you can't do everything, but one thing that's really lacking, patients want this education, and knowing that you have their permission to provide this can be incredibly impactful. So talking to patients, if you have patient family advisory councils, to really find out how would we approach this and how can we better provide this education may be really helpful. Other education we need is how to communicate and present. I think that we just expect sometimes that because I can teach a patient, I can walk into a room and do a presentation, but we really need to build that capacity to make sure that we are able to have the confidence in presentations so that we're comfortable standing in front of this group talking about sex. And learn what others at your site are teaching and what aspects of sexual health you can teach. There are going to be things that you're better at than others and vice versa. Let's engage our mental health experts to really talk about some of those mental components of sexual health. And if you're more of an exercise person, great, let's use that to our advantage. If you're interested in this infographic, just reach out to me. I'm more than happy to share it. My thesis is also not hundreds of pages long. It is 105 pages long. So I'm also happy to share it. It's on University of Manitoba MSpace. It's 105 pages actually counted, and that's including my references. Before I open up to questions, I just want to take a moment to thank my major funders, Research Manitoba, Canadian Nurses Foundation, MCNHR, and the College of Nursing, along with my committee and our cardiac sciences program at St. Boniface Hospital in Winnipeg. And if you want references to this, please just reach out to me and ask. But really interested to hear people's questions, comments. And do I have to stop sharing, Sue?
Right.